Next, we got DI, which is diabetes insipidus, not to be confused with diabetes mellitus or mellitus. As you can see from the photographs that are here, this person is going to be running to the bathroom and reaching for water. Diabetes insipidus refers to the condition where the kidneys are really unable to retain water, and even though the patient may be dehydrated, the kidneys can't really balance the fluid and produce large amounts of insipid urine. And so they're constantly going to the restroom, diuresing. There's polyuria, but the urine is actually very dilute. Normally, we know, of course, the kidneys produce 1 to 2 quarts a day, but with this particular condition, you're talking about 3 up to 20 quarts a day of urine that are being produced because of the need to rid the body of high levels of glucose. So patients going to obviously feel very thirsty and have the urge to drink large amounts of fluids. In this case, for this particular diagnosis, your outcome for this patient is going to be to prevent dehydration. Number one, manage the symptoms and prevent any complications or reoccurrence. It's going to present itself subjectively with, excessive thirst, polyuria, excessive urination, possibly, subjective signs of headache and fatigue and dry mouth. Objectively, as you are assessing a patient, you will likely see, when you're looking at their mucous membranes, for example, dryness. Looking at their skin turgor, it's going to be a decreased turgor. For people of color, you're going to make sure that you're assessing not just their exterior skin, but looking at their mucous membranes and their conjunctiva, looking inside their mouth. Another clear objective sign for DI is going to be tachycardia. Some instances of weight loss, because now you have risk for fluid volume deficit because of the increased polyuria. Hypotension obviously connects when you think about the patho, because of the increased ridding of fluids in the body, you have low fluid volume in the body, and so your blood pressure is going to be low. Hypernatremia, because your body's retaining that salt, and then related to what we talked about a moment ago with turgor, you're going to have a decrease in skin elasticity because your level of fluids in the body is drastically decreased. Weight loss will occur with excess fluid loss, and thirst is going to be a key sign. This is going to present with abnormal blood sugar levels, so you're going to make sure that you're monitoring those glucose levels. Early detection and intervention are key, because when not treated early and often, this can definitely lead to hypovolemic shock. So you're going to assist the patient when standing, because when you've got low blood pressure, just like with orthostatic hypotension, you've got a risk for falls, risk for injury. So safety and fall precautions are going to be critical. Educating the patient on slow position changes, just like, if they had orthostatic hypotension. In this case of DI, they have regular hypotension. So slow position changes. If they do have intact thirst and they're not NPO, of course, you're going to provide them water, preferably, to stay hydrated. But in most instances, especially inpatient, you're going to have IV fluids. And so you're going to need to set up an IV, assess that IV site, and maintain normal saline or another fluid per provider order. Monitoring electrolytes is going to be key, because when excess fluids are lost, the body begins to secrete potassium and hold on to sodium. So that comes with, of course, dietary changes that have to happen. Can't eat sodium if you're hyponatremic. Again, fall precautions, so assisting with ambulation, making sure a bathroom is accessible and nearby, and they know where it's at and how to get to it, or at least know where the call light is and how to ask for help because of the polyuria. And that's in the cases where they don't have a Foley catheter. If they do have a Foley catheter, then do expect to monitor IOs and prepare to do frequent changes or emptying of that catheter bag because of the increased diuresis. Also, one thing to consider as a nurse with DI is, because of polyuria, especially in geriatric patients or patients with disabilities, there's a risk for incontinence or there may already be incontinence. So you need to assess skin integrity and monitor for skin breakdown, helping them with ADLs and skin hygiene so that they don't get any skin breaks or ulcers, because that's a increased complication for patients with diabetes, because we know how high glucose levels slow down the healing of wounds.